Hello, everyone. I'm Dr. Carmen Pugliafito. I'm here today with Professor Pearse Keane from London and the Moorfields Eye Hospital. Pearse, welcome back to Retina Synthesis.
Thank you, Carmen. It's a pleasure to speak to you again.
You gave a very provocative talk at the angiogenesis meeting in Miami, and really at the intersection of two extremely hot areas, artificial intelligence and geographic atrophy, macular disease. So can you give us a 35,000-foot view of what's going on in these two areas at their intersection from your point of view?
So I think there's been so many advances in AI outside of healthcare. We've started to see them percolate into ophthalmology in the last few years. One of the things that we definitely know that we can do now is use AI to do better automated quantification of disease features on eye scans, and particular OCT scans. So we can automate the process of segmenting OCTs in a much more accurate way than we could in the past. Now, one of the main areas where that has been focused on is in dry AMD, and particularly in geographic atrophy. So there's now a number of different AI systems that can quantify geographic atrophy on OCT volume scans, and they can do it in ways that are consistent with the CAM criteria for assessing geographic atrophy. So they can break it down into different components like choroidal hypertransmission and photoreceptor loss and RP loss and so on. And so I guess what I wanted to highlight is that we've now a number of groups have published a few interesting research papers, including from Moorfields and from myself and my collaborators. But where do we go from here, and how can we actually make this into something clinically meaningful? And I think that there's a few ways of thinking of this, but one of the major forks is, does this need to be a medical device that actually directs clinical care? And with all the regulatory kind of challenges associated with that? Or are there impactful things that we could do in a research setting, even without regulatory approval? So maybe just having these AI systems would lead to better post-hoc analysis of clinical trial data, better structure-function correlations, something like that. Or one of the things that I'm particularly excited about is, could we use these systems to improve the feasibility planning for clinical trials, or improve pre-screening for clinical trials, or even screening for clinical trials? And, could that be a powerful use case that that might not require regulatory approval, depending on the exact setting that it's used? So that was something that I talked about. But then the other big thing was, I think that there's this real interest in using AI to do better predictive modeling. And this idea that we can better quantify OCT scans and then therefore better predict which patients with geographic atrophy are going to rapidly progress. And therefore that could be something that helps recruit people into trials, or therefore help in day-to-day life. And so in my talk, I described 4 recent papers from leading groups around the world, work from the AREDS2 OCT sub-study from Nora Ladd and others, work from Roche Genentech from their lampalizumab trials, work from Phil Rosenfeld and others in Florida, and work from Ursula Schmitter-Fort in Austria. And so these are nice papers, but I guess I really just wanted to say, how do we know what the finish line is for this predictive modeling? Like, at what point do we say this is done, this is ready to now be implemented? Do we have a sense of what that looks like? And then the other point that I wanted to, and you may have opinions on this as well, but is this something that is likely to be required for clinical care by payers? Which is to say, we could have more licensed drugs for dry AMD, but will the payers require us to have some sort of analytic system that predicts progressors or does better measurements over time? Or will they simply say, just go crazy, use it as it stands? Because I think those are key things that we need to find out, and the sooner the better.
Well, with the pegcetacoplan approval, it's wide open. You have a treatment interval of 1 to 2 months, and the clinical indication is geographic atrophy. No clinical characterization, OCT characterization, or fluorescein or autofluorescent characterization. And we have no biomarkers. And doing automated analysis of geographic atrophy is not really possible. In the clinical trials, the lesions were hand traced. So my vision is a world in which artificial intelligence could drive quantitative characterization of geographic atrophy and its progression, and whether or not therapeutic intervention is working. What do you think about that?
But so what happens if we're just allowed to use these drugs, and your average retina specialist in the street, say for example in the UK, there's no requirement upon them to actually quantify or track changes in this way? Do you think people will, in that scenario, why would the imaging companies spend a lot of money to get a regulatory approved AI tool that can do this quantification?
Well, I think your sensitivity to the regulatory dimension here is really welcome. But I'm looking forward to the future, because we're going to be looking, I think, at anti-complement intervention at earlier stages of the disease. I think Phil Rosenfeld has really identified how drusen progressed to geographic atrophy in very early stages, and is currently heading a clinical trial looking at an agent for treating that. So I don't think we're going to change pegcetacoplan's treatment indication, but going forward, artificial intelligence may be very important in looking at extremely large data sets.
But how do we, so I think one of the challenges though in our field is that we have a number of different groups all around the world developing these algorithms on relatively small data sets, and with a relative lack of external validation of the models that they're producing. And how do we sort of, as a field, move forward where we can somehow kind of unify all of that work?
Well, it would be good in future clinical trials, as you really alluded to look at a subgroup of the patients. And some of these clinical trials have been large. In the pegcetacoplan trial, it was 1,200 eyes. So some subgroup could have been analyzed with artificial intelligence. Now, manufacturers may be reluctant to undergo this, but I think that there's going to be a demand from the clinical aspect, from clinicians and from regulatory authorities, for some validation of therapeutic effect. And from patients.
Well, maybe that will be the key thing. Patient needs, are patients going to want to just use this if they have no sort of metric that shows that it's benefiting them?
But
perhaps not.
The key question for you as the expert is, will artificial intelligence be powerful enough to do what we're alluding to?
So I think that's another really good point. So clearly we can quantify now anything that a human expert can quantify. And we can do that in an automated, reliable fashion. But I think that there's this hope that AI will somehow elucidate some kind of magical biomarkers that are hitherto unknown to us as a specialty.
Mhm.
And I think even though I'm an advocate for AI and I'm super enthusiastic about it, it's a bit of a long shot, I can tell you, that we're going to find something like that, because the data sets that we have are still relatively small by comparison of the data sets that AI is being exposed to outside healthcare,
Yes.
where it's like everything on the internet. It's billions and billions of words of text. And we're saying, well, we've got a big trial. It's like 2,000 patients. It's small potatoes, actually, in some ways, compared.
Well, it's a very sober analysis. And I mean, and I think it goes to your skill as an investigator that you're raising this question as an enthusiast.
So what I think actually the really cool use case is going to be is, imagine you have an AI system that can run on, imagine it can run on your fundus autofluorescence image database or on your OCT database, whatever manufacturer that's from, and you simply get it. It might be from a drug company, it might be from some other company that's made it, and you could just run it in a batch form on your Heidelberg database, for example, and it would just automatically, over the course of maybe a couple of nights, it would just run on hundreds of thousands or millions of OCT volumes and identify every patient that it thinks has geographic atrophy due to AMD. And then it could be broken down into whether it's foveal or extrafoveal. It could even generate lesion size metrics. And then wouldn't that be amazing for clinical trial recruitment or for new drugs and things like that? Rather than the approach that we have, at least in Moorfields, I don't know how it is in places you've worked, but for clinical trials, we have like laminated pieces of card in the waiting rooms, or we have clinical trial recruiters who manually look up the list of every patient that's coming to the clinic next week, and they manually spend lots of time looking through. Or we try and get billing codes from the electronic health records that are like really, really noisy. I just think that AI is going to identify the people that are suitable. And then if we see if the patients are still alive, and then we can offer them the chance to come into these trials.
Yeah, recruitment is extraordinarily empirical.
Yeah.
And from my experience at a reading center, there is tremendous heterogeneity in the eyes with geographic atrophy that are recruited.
Yeah.
And
yeah.
if we had some way of identifying the eyes that we would like to study the most, that would be a tremendous advance.
Yeah.
And I think what you're proposing is feasible.
Yeah.
In the short term.
I think so. So what I'm saying is, let's think about what are the short-term wins that AI could provide that could be potentially transformative to us. And if we happen to, along the way, discover some like new magical biomarker that AI has allowed us to uncover that humans have never detected, then that's great. But I don't think that should be the primary focus.
Mm-hmm. Well, we know that geographic atrophy is going to be the subject of extensive investigation. It will be the #1 topic in the management of macular disease. It will surpass neovascular AMD in the amount of investigative power in exercised. So I think that AI will play an important role in even in these early stages. I think what you're saying is fantastic, which is some small victories would be fantastic.
Yeah. And I mean, this is why I like talking to you as well, because for me, it's about going beyond just publishing a research paper. It's about actually getting this translated into something in our devices that actually brings benefits.
Well, listen, this has been a great discussion, and we look forward to coming back to you in a number of months to figure out what's going on. Thank you, Pearse.
My pleasure.